All right. So in terms of disclosures, I don't have any financial arrangements related to the content of this activity. Our title today is Helping Patients Make Positive Change. So we've talked before about the basics of motivational interviewing and the trans-theoretical model of change. We wanted to restructure it just a little bit to really focus on particularly harnessing, as Dr. Jacobson mentioned, people's New Year's commitment, that idea of people who are maybe thinking about making positive changes, but haven't taken the first step yet. And that's where we'll focus today on what strategies will be helpful. So our objectives today are first to discuss the key characteristics of each stage in the trans-theoretical model of change. We'll review the introductory principles of motivational interviewing in relation to substance use as well as other health behaviors. And we'll identify accessible strategies that can be applied across settings to support patients in making health promoting changes. We'll move fast today. We want to make sure that we leave plenty of time for the case. So any questions you have or anything you'd like me to elaborate on, please put it in the chat and I'll return to it in questions and answers. So I did want to start out this presentation with sort of an odd move, which is putting the takeaways up front, because I'm hoping this will help you sort of foreground which strategies are going to be most relevant for you, either for an individual patient that you have in mind or for the type of patient or patient presentation you tend to see in your setting. So these are sort of just the 4 quickest and dirtiest takeaways that we'll end up with. The first is to make sure that you're matching your stage of change effectively to whatever intervention you're applying, because that's where you're going to get the most mileage or be unsuccessful if you don't match it. Highlighting successes, this is really the fun one. This is just making sure that we're being a cheerleader for our patients, because a lot of what we'll talk about today is how lack of confidence and lack of ability to see their own agency or recognize their own agency and autonomy can sometimes stand in the way of patients making change. So really just highlighting any kind of small successes or accomplishments that they might be overlooking. Third, encouraging autonomy. This is one of the biggest ingredients in terms of actually making the change. So we're wanting to make sure that we're helping the patient recognize and capitalize on whatever their reasons for change might be, rather than our own or somebody else's. And then lastly, and I put it this way because it is counterintuitive, is to use our ears more than we use our mouth when it specifically comes to working with patients who are considering change, but not ready yet, because it's human nature that we want to dive in and really push them along when we see the opportunity. But what we'll talk about today is how that actually can be counterproductive, and that stepping back and listening and just setting the stage for them is actually more effective. So we'll start out with the trans-theoretical stages of change model. This is an evidence-based model that matches where a patient is at with what they actually need in order to benefit from treatment. So it's not an intervention in itself, it's actually an assessment, but it's a very, very useful one because, as I mentioned before, if we're not matching intervention with stage, we're potentially wasting a lot of energy and alienating the patient. I do want to mention, because stages of change is often talked about in the same breath as motivational interviewing, that they are 2 completely distinct concepts. They came out of the same body of research. They're very often used alongside each other, but they are 2 different things, and we'll be talking about them next to each other today. The main idea here being that motivational interviewing is best applied during one particular stage of change, and that's why it's so important to make sure that we're applying it during the right time. So with this graphic of the stages of change, it shows this sort of neat orderly progression of each different stage, which is each different colored arrow. And I will say, in real life, it rarely is quite this linear. Usually people are sort of popping in and out at different stages. But in terms of learning and conceptualizing the stages of change, it's easiest to think of it as moving in a clockwise direction, starting with pre-contemplation. So we'll start there. When people are in pre-contemplation, that means that they really don't have any intention of changing their behavior. They might have been told that it's a problem, but they generally are not thinking of it as a problem themselves, or at least not one that they're interested at all in changing. In contemplation, there's this shift where there is a recognition that there may be a problem or a change that could be made, but the person is really on the fence about it. They recognize both the benefits of a change and also the benefits of the status quo more or less equally. In the preparation stage, they have made an internal commitment, they want to move into action, and they're really in the planning stage. So nothing concrete has happened yet, but there's been this internal shift where they're starting to commit. In the action stage, that's where the concrete things start happening. That's where the patient is actively modifying their behavior and making this shift from the old behaviors into whatever the new behaviors may be. Maintenance is where action has really become instantiated as simply the way rather than a new behavior, a new change. So it's where people have really gotten invested. They've made major changes in their life to accommodate this behavior shift, and they're really moving into a different stage of life because of it in many ways. I really want to point out that the yellow arrow here, relapse, is rule rather than exception most of the time. We tend to be scared of the word relapse and sometimes can inadvertently communicate that to patients who often also are very worried about relapse. But the reality is it's very, very normal. And the more that we can talk about why it's normal and how it's part of the process and why we don't need to stigmatize it so much, the more helpful we can be to our patients. So before I go into a few more details about each stage, I just want to point out that the internal graphic here is that this is an upward spiral. And we really want to emphasize when we talk to patients that this isn't them going in circles when they're repeating different stages. It's a spiral staircase. They're always moving up as long as they're learning from each stage that they've been through. That's particularly applicable, of course, to relapse. So in the pre-contemplation stage, again, they're not really recognizing there's a problem. They're not thinking much about changing. Your goals here as their provider are just to give them the opportunity to let the awareness come to the surface about the problem so that they can start chewing it over. And really the biggest thing is keeping them engaged in the process. So that's about building rapport and making sure that you have a really strong, positive relationship, that they know they can count on you and be honest with you. The contemplation stage we'll talk about more in a few minutes is just ideal for motivational interviewing. Contemplation is where they're thinking about making a change, not ready yet. Your goal here is to help them prepare to move towards action. You're going to keep the person talking about change. Lots of research in motivational interviewing that change talk is the biggest indicator of successful change. So anytime they're saying, well, maybe I could, or it would be really nice, you really want to lean in and indicate, tell me more about that. Curry their enthusiasm to discuss it. You're boosting their awareness of change options. So an example there that comes up a lot is people think they have to go cold turkey when they're making a change. And this is a great place to introduce the idea of incremental change and harm reduction. So rather than saying, if you're not ready to go from 1 gram to 0 today, why don't you try moving down to 0.8 of a gram? That would really be a very significant shift. So just sort of broadening their idea of what's possible with change. And then, of course, helping them to recognize the benefit of change or their perception of it. So when discrepancies come up, when they're saying, I don't know, I don't think I'm ready, but also, gosh, it's so hard on my family, you lean in on that and you say, okay, well, yeah, what are your values here? What's most important to you? How is it affecting you? So that they can start to see that the scales are not balancing. You're supporting their self-efficacy. So again, really making sure that they're building all the confidence that they can and the sense of optimism based on what they've accomplished in the past, based on their commitment or their actions now, and particularly leaning into reminding them that it's their right and their ability to make decisions for themselves. So really building that autonomy for them. When discord arises during this stage, that is simply a signal for you to step back into the pre-contemplation maneuvers of just building rapport. So it means usually that we've stepped a little too far into being directive, and the person has started to come up with that psychological reactance of wanting to resist or assert their own autonomy. A great just universal verbal strategy here is rather than using the phrase yes, but when you hear something they say that doesn't quite make sense, is to say yes and, because people tend to be much more receptive to this language, whereas yes, but tends to feel confrontational. In the action stage, the person is ready to make the initial attempt to change behaviors. Very often they don't have the confidence yet, so they have the intention, but they don't quite have the momentum. And you really want to make sure you're building up their confidence in all the ways you can. You're encouraging progress, you're being a cheerleader. In cases where you can anticipate obstacles, you're helping them to remove or diminish them. The one thing here that's counterintuitive is just that you want to restrain excessive change. So very often in action stage, people will get so enthusiastic that they bite off more than they can chew, and then that creates a failure which demoralizes them. So when you notice that happening, you just want to say, hey, why don't we just take a smaller bite? Let's make sure we set you up for success. And that's a way to make sure that their momentum keeps moving forward. In maintenance, this is really the place for relapse prevention skills between action and maintenance, and particularly in maintenance. They're integrating those changes into daily life. You're keeping their motivation up now that the big push has kind of culminated. You're making sure that they understand all their triggers, developing a plan for coping with the triggers, and especially you're making a plan for how they're going to re-enter this cycle of change effectively if and when relapse occurs. The biggest point here, and this is just the sort of pocket intervention that can make such a huge difference, is talking about what's called the abstinence violation effect. And that's this thing where it's just a very natural human reaction when relapse occurs to say, oh, well, I'm going to throw it all away. I worked so hard. It's all over. I messed up. I'm done. I've had a patient call it getting a case of the screw-its. And I think that's a great way to phrase it, because it's really this idea that you kind of throw the baby out with the bathwater. And that's a very normal cognitive response. If you can tell patients ahead of time that that's likely to happen to them, so prepare them to think through what they actually want to do at that moment, they're much more likely to be able to draw on their autonomy and say, this is a fork in the road. It's not an expressway back to the old habits. So they can choose to just make that slip a detour rather than going all the way back to the old path. So just talking through the abstinence violation effect ahead of time is an incredibly effective intervention to help make sure that when relapse occurs, they can get back very quickly to where they want to go. Again, relapse is very common. It's not a sign of failure. We want to make sure we're psychoeducating patients about this. It's normal in any type of chronic illness management in terms of symptom remission and resurgence. And just remembering that our language around relapse can have a really profound effect on how patients experience it. So we really want to structure it as a learning opportunity, that on that spiral staircase, once they've learned from their relapse, then they're going to be able to see it coming next time. They're going to be much less vulnerable. They're able to learn from it. So again, our superordinate goals here: avoid help having them become discouraged, and helping them to re-engage effectively in the change process. So we're gonna take a little turn now to motivational interviewing in the spirit of MI. It'll, I think, be clear why these are compatible. This quote from the originators, I think, encapsulates a lot of what we'll talk about here, which is, people are the undisputed experts on themselves. No one has been with them longer or knows them better than they do themselves. When we think about the big picture of MI, the big idea is that it's an effective method for talking with people about change. And I emphasize with because the originators really talk a lot about how upset they get when they hear people talking about doing MI to somebody or MIing somebody. And they say this is just fundamentally antithetical to the spirit of MI and the idea that it's a collaboration and a partnership. So we really want to keep that stance in mind as we talk about it. It is person-centered in the sense that it's client-led, but we do have a directionality in the sense that we're guiding as the provider to help elicit and strengthen motivation for change. So while we are theoretically unattached to outcomes, which is a very difficult thing to do as a human, we do, of course, have the ultimate goal of helping to strengthen a person's motivation for change and support them in that effort. We do use this method clinically, specifically when a person might benefit from making a behavior or lifestyle change, but they're ambivalent about doing so, as we discussed earlier. So I'll talk more about ambivalence because this is a really key principle when we talk about the basics of MI. And it's the same clinically as it is in general language. It's just this idea of feeling two seemingly contradictory things at once. It often appears to us as a lack of motivation because we can't see internally that there is this kind of struggle going on between I do want to change, but I don't know that I'm ready, or there's so many good things about the way that things are already going. So those both sides are already present within the person, and we can't always see that from the outside. We only get to find out if we earn the person's trust and are able to hear it from them directly. It's a very normal part of the change process. It's common prior to as well as during habit change. And one of the things that come up with ambivalence is what's called the communication trap. So it's very normal that when in conversation, one person presents one point of view, it naturally prompts the other person to defend the other side. And that's just something about human nature that happens to most people, but we fall into it very easily as providers when we get enthusiastic about trying to say, this is why you should change, or we catch a corner of that ambivalence and try to really be a little more coercive than we realize perhaps about driving somebody towards it. The reality is that when we do that, when we're talking about change as the best and the only option, it actually prompts the patient to defend the status quo, so it makes change less likely. So what goes along with the communication trap is the righting reflex. So what is that? That's the natural inclination we have to fix things for another person. It comes from the most well-intentioned place in our hearts, and most providers have this because we become providers because we want to help people. The danger of the righting reflex is that it causes us to tell the other person what to do, how to do it, why they should do it, without actually having that full listening conversation where we learn what their motivations are, what their pathways are according to them. So it does create resistance whenever we're moving away from that partnering alongside stance that's so characteristic of MI and moving into that expert top-down role. So the writing reflex happens because of several implicit assumptions. It tends to be that when we see somebody who's not making a change that seems very obvious it would be good for them, we think, oh, they just don't see how much better life would be. They don't know. They don't know how to make the change. They must not care that much. And so the writing reflex is us wanting to step in and say, I can just give them this insight. I can provide them with knowledge and skills. This will fix it. Unfortunately, the consequences of the writing reflex are that, the patients may sort of superficially make a change or make a change briefly if they really like us, but it's not for their own purposes, so it's not going to stick. We really need the motivation to come from them. They might listen politely and then go ahead and do whatever they were going to do in the first place. I suspect we've all had that experience. In any case, it can be that the patient protests and then that prompts us to push harder. Nobody benefits from this. We end up just locking horns and very often we blame the patient and we say it's because they're resistant or they're not motivated without recognizing that accidentally we actually engaged their resistance and made it harder for them to change. So this is just a graphic to help you remember when you start to notice that writing reflex kicking into action. It feels like it's gonna help things. It seems like it would, but actually it's just strengthening the resistance when you're engaging with ambivalence by telling people what they should do about it. So what do we do about the writing reflex? We use the rule. First part is just resisting it. So that's really just recognizing that it's happening when you notice that impulse of, I can fix this, I can tell them what to do coming up. Then you want to make sure you step back, take corrective action by checking to understand your patient's motivation. You do that, of course, by listening. And then you're also empowering your patient to say, it's your decision. You are free to decide what to do. Let me know how I can support you. So when we think about the components of MI, something to emphasize as we move into talking about the spirit of MI is that, well, the skills and techniques, the processes and the principles, those are all kind of finesse pieces, and they can be pretty complicated. If you do want to do full training on MI, you also can still get a tremendous amount out of simply understanding and embracing the spirit of MI, because that's really the foundation that undergirds all of those sort of more complicated technical pieces. So the spirit of MI can be broken into three different pieces: acceptance, collaboration, and evocation. With acceptance, we're saying that as a counterpoint to authority. That's really about accepting people just as they are. We're not judging them, whatever their current health behavior is. Our opinion of them is not contingent on that. What's helpful here is what's called the Rogerian paradox, which is that we find that when people actually are accepted just as they are without conditions about who they need to be or how they need to act, that actually frees them up to change because they're no longer invested in fighting this battle of defending what they're currently doing of their status quo. This entails accurate empathy, so really striving to understand things from their perspective, supporting their autonomy, again, really emphasizing that it is their right and their ability, their freedom to make their own choices. And of course, again, affirmation, really communicating appreciation of their strengths, of their accomplishments, communicating your sense of confidence in their ability to do what's right for them. Collaboration is a counterpoint to confrontation. So again, it's just that posture that we're actively collaborating. As providers, we're clinical or medical experts, but the patient is an expert on themselves, and nobody can be more of an expert on themselves than the patient. The metaphor is often dancing rather than wrestling because it is this sort of dynamic exchange rather than a top-down effort at domination. It's about exploration. And again, thinking of our language, it's conducted for and with rather than to a person. And I can't say it enough, patients are the experts on themselves. They often really do already know what they want and even how to go about it. And our job is to bring that into the room and set the stage, make it possible for them to act on that. Then lastly, evocation, that's a counterpoint to education. So that's about communicating your confidence that they have what they need, that as a team, we can bring it forth. We want to make sure that we're not buying into their lack of confidence if they're just waiting for the time to be right, because that's very often the hesitation. That's where we can help them with, moving into incremental change and just inquiring about what might fit for them with these other options for change. That's part of the increasing their awareness of different options for change. We're evoking and strengthening whatever motivations are already present. So really just building on their own why. And just again, as always, leaning into understanding their perspective and their wisdom rather than bringing in our own perspective. So in wrapping up, I did just want to mention, we don't have time to delve into it. There's some really exciting recent research on culturally adapted motivational interviewing. MI is really well suited for culturally responsive interventions precisely because it's really led by the patient. And this is a broad framework that helps us focus on incorporating cultural values, customs, and traditions, making sure that we're addressing the concepts that are most salient or most prominent for this person based on their background and culture. And in particular, making sure that we're recognizing the context in which they arrive in treatment, including macro and meso factors like geopolitical or socioeconomic factors that may be impacting their readiness for change in their circumstances. And I'll wrap up just by saying the research on motivational interviewing is very strong. We have several decades now. It keeps pointing in the same direction. What's great is that it's being expanded into other comorbidities as well, other mental health conditions. The one thing I'll highlight here, because I think it really goes back to how powerful the spirit of MI is that in the earliest studies, the outcomes were actually better when no manual was used. And when they went back to figure out why that was, they realized that in these early pilot studies, there was a component where at the end of each session, the patient had to make a change plan, whether or not they indicated readiness. And invariably in the conditions where the clinicians were not using a manual, they were attuning as to whether the patient was ready or not. So they weren't forcing that change plan if the person wasn't ready. So that theoretically, and it certainly makes sense, is why those patients were more successful. So I think that says a lot about how just the spirit of MI alone can get us very far. So in terms of resources, they don't have a calendar up for 2025 yet, but this is a local organization that provides motivational interviewing training very often for free through the SOAR grant. So keep an eye on that calendar if you're interested in getting trained in MI. And then there's also a link here to the Socrates assessment instrument, which has to do with the stages of change and readiness for treatment. So I know we went fast there. I'll stop sharing and see what questions or comments you all may have.